We present a case of endothelial transplantation assisted by femtosecond laser, combined with cataract surgery, also assisted by femtosecond laser. First, we will use the laser to perform the continuous circular anterior capsulorhexis and then make the cuts in the lens. Next, centered on the limbus, we will perform an endotheliotomy with the femtosecond laser. Here, with real-time OCT, we can see that we are able to adjust the cutting parameters, slightly affecting the stroma, as shown here in the image. Once we have performed the endotheliotomy, we proceed to make the paracentesis. We release the anterior capsule that was cut with the laser. Next, we will proceed with the phacoemulsification of the lens, starting this procedure by breaking up the nucleus with this pre-chopper and then using the phacoemulsification system to aspirate the nuclear fragments. These fragments are easily aspirated. It is not a very hard cataract. Next, using the irrigation/aspiration device, with this handpiece we will aspirate the residual cortical and epinuclear material, leaving the capsular bag well polished. And once the cleaning of all the cortical masses is completed and the capsular bag is polished, we proceed with the implantation of an intraocular lens. It is a monoblock intraocular lens made of a hydrophobic material to prevent opacification. Once the lens is in place, with a controlled unfolding inside the capsular bag and positioned horizontally, we proceed to remove the recipient's Decimet membrane. We do this using a reverse Sinskey hook, pulling tangentially and trying not to insert the Sinskey hook into the small incision made by the femtosecond laser in the posterior stroma. With these dragging movements, without scraping the posterior stroma to avoid damaging it, we complete the decimeter hexis over the full 360 degrees and then, afterwards, with the help of forceps, we remove the Decimet membrane in its entirety. We carefully insert the delicate forceps and gently remove this thin Decimet membrane, which we then meticulously spread out on the anterior surface of the cornea to thoroughly confirm that it has been completely and entirely removed from the eye. Once it is spread out, we can see that the laser had minimal impact on the posterior stroma, and with the intraoperative OCT, we confirm the correct orientation of the scroll inside the injection cartridge, which is then injected into the anterior chamber. We use the OCT to verify the correct orientation of the donor tissue. We proceed to unfold it using tapping maneuvers on the corneal epithelium, depressing the cornea and collapsing the chamber, which makes it easier to spread out. And once we have it centered and properly positioned, we will place an intracameral gas bubble. This will help us keep the graft in position and facilitate its adhesion. We completely fill the anterior chamber with gas. We maintain this situation for about half an hour, then partially remove the gas and let the patient go home. Here you can see the final result, with the donor tissue perfectly centered with the endotheliotomy, all the way around 360 degrees. It is perfectly positioned, as confirmed by the OCT. The incision marks can also be seen with this imaging system. Here, then, we will later partially remove the gas, leaving the iridotomy we performed in the lower part clear, and place a contact lens.